So what goes into the evaluation of childhood headaches? Well, first of all, we take a very careful history. And often from the history, I start figuring out whether it's a primary headache or a secondary headache. And then once I narrow it down, I can further decide if it's a migraine, tension, or cluster headache. I'll start off with some questions of age of onset. So we know that certain headache syndromes, such as migraines, tend to start at a younger age than, say, cluster headaches or some other forms of headaches. Migraine headaches, for example, will have an aura or prodrome to them. That means there'll be sort of a neurologic change or some sort of symptoms before the headache come on that you don't see with tension headaches. We'll talk about the quality of the headache. That's where migraine headaches will have a throbbing sort of quality. Tension headaches, maybe more of a squeezing, and then cluster headaches, something like a stabbing pain to them. We'll talk about the site of the headaches. One thing that I like to have is the headache occurs in different parts of the head. If a child can point to a specific part of the head and say, my headache always occurs just in this spot, it makes me a little bit more concerned of something besides a primary headache syndrome. We also know that migraines in children tend to occur frontally or possibly in the parietal area on the sides. So I'll often ask detailed questions about where the site of the headache is, where the headache starts from. One interesting sort of headache that I see occasionally in children and is very underdiagnosed are musculoskeletal headaches. These are headaches that occur in usually the back part of the head, in the upper cervical, top part of the neck or occipital area. And often these will be children that have had extensive treatment directed towards either migraine or tension headaches. And when I do the examination or take the history, I get a very good story compelling for some sort of neck strain or some sort of tension in the muscles in the back of the neck. We might call a musculoskeletal style of headache. I always take a careful family history in knowing that some headache syndromes like migraines tend to run in families. And then we'll get on to the examination. We'll always want a careful neurological examination, although this is often less important than a careful history, especially in determining different sorts of primary headache syndromes. A neurological examination will include things like weight and blood pressure. We'll look carefully at the eyes, maybe use something called a fundoscope to look at the retina, and fundoscopy, look for signs of increased pressure in the brain. An important part of it is to examine the neck and suboccipital areas for the musculoskeletal causes for headaches. And then a complete neurological examination, everything from cranial nerves, how the eyes move, how the facial muscles are working, strength and reflexes, balance and coordination. A good comprehensive neurological examination will take around 15 to 20 minutes and is important in determining, is this just a primary headache syndrome or is there more to the story, something for us to be worried about if we find any sorts of abnormalities. Now, if anything comes up on the examination or history that's suspicious for secondary headaches, we'll talk about neuroimaging. This is an important one that comes up a lot. Many families in my office think we should automatically do a CT scan or MRI for any child who has headaches. Now, the American Academy of Neurology and the American Academy of Pediatrics in their practice parameters limit the recommendation of neuroimaging for children who have any sort of signs for secondary headaches. If a child comes in as a very typical story for migraines, they have a frontal headache that's throbbing, maybe with a family history, it's been recurrent, lasting 2 to 6 hours, associated nausea, maybe sensitivity to light. For those children, I don't necessarily order any neuroimaging, CT scan or MRI. If I do find anything by history or exam that makes me suspicious of secondary headaches, that means something being wrong with the brain, I'll often order an MRI instead of a CT scan. The reason for this being that an MRI is more sensitive. If we do a CT scan, sometimes we get the results back and we'll say, well, it was normal, but it was just a CT scan. I wonder if we should do an MRI. And then at the same time, if we do a CT scan and we find an abnormality, sometimes we think, well, there was something abnormal here on CT scan. We better do an MRI. And so often the end point is doing an MRI.